Bismillah ar-Rahman ar-Rahim. Ladies and gentlemen, good evening and welcome to the first imaging working group multimodality rounds for the year 2023. My name is Firas Al-Badareen. I'm a cardiologist and multimodality imager from Cleveland Clinic, Abu Dhabi, and the head of the imaging working group of Emirates Cardiac Society. Today, we have prepared for you a stellar program with an amazing lineup of speakers, cases, and controversial topics. Today, we're going to discuss a topic that is at the heart of what we do day in and day out as cardiologists. We're going to discuss the recent implications of chest pain guidelines that were released in 2021. Without further ado, we're going to go ahead and get started. We will have three didactic presentations. We'll have a panel discussion, and then we will proceed with a couple of case discussions to show how these guidelines can be put into practice in real-life scenarios. This is live, so feel free to send us your questions to the platform, and we will try to address them in a timely fashion. I'm very fortunate today to be joined with a few friends and colleagues from the imaging community here in Emirates Cardiac Society. I have Dr. Amrish Agarwal, who is a consultant cardiologist at the Fujairah Hospital and avid cardiac imager. We also have Dr. Safa Al-Muhdar from Zaid Military Hospital, who's also an advanced multimodality imager. In addition, I have Dr. Walid Al-Tahlawi from Cleveland Clinic, Abu Dhabi, who's particularly a cardiac MRI expert. And last but not least, Dr. Hassan Khan, who's expert in, who's an associate physician at Cleveland Clinic Abu Dhabi as an expert in echocardiography, cardiac CT, and nuclear cardiology. Welcome, everyone, and thank you so much for joining us. The first presentation is going to be an overview on recent chest pain guidelines provided by Dr. Amrish Agarwal. Dr. Amrish, the floor is yours.
Good evening, ladies and gentlemen, and it's really a pleasure to be once again. It's an excellent program, and all of us will benefit immensely by it. So over the years, the concept and the guidelines regarding stable part of the chest pain which is kind of stable and presently the outpatient clinic, had changed over these times. So one of the first guidelines to address was 2019 guidelines of European Society of Cardiology, which actually changed the terminology from stable coronary disease to chronic coronary syndrome. The reason being is that chronic coronary syndrome actually characterizes the patient more correctly. The patient stable is a misnomer because the process of the patient in a stable coronary disease remains stable for a long period of time and unpredictably and suddenly all of a sudden can become stable. So the terminology they suggested to use the word chronic coronary syndrome. And they suggested 5 scenarios which are commonly seen in the clinical practice. But for our today's talk, the 2 scenarios which are relevant is the patient with suspected coronary artery disease and the stable angina symptom, which will be mainly the focus of the talk, and patient with angina symptoms and who don't have any obstructive coronary artery disease, in which we suspect vasospastic and microvascular disease. And these type of patients are more prevalent with the women population, hypertensive population, elderly population. So these people have angina or feature suggestive angina, but the imaging modalities, they actually show the coronary arteries normal. So in 2021, and these guidelines were published somewhat later, the American people, the American colleagues, they came out with their new guidelines, which they said is they called it chest pain guidelines. And in 2022, they came out with the clinical decision pathways. But those clinical decision pathways are mainly applicable to the patient in the accident emergency department. It's a pretty bulky document. It has got 99 pages, and the slide set, which is given by the society, contains 116 slides. So I have really tried to condense what we find in the slide set to this current relevant presentation, which I'm going to spend in the next 20 minutes. These society guidelines are very, very comprehensive. They are just not endorsed by American Heart Association, American College, but they also are endorsed by the American Society of Echo, American College of Chest Physician, and for that matter, Society of Cardiac CT and the Cardiac MRI. So all these people, they are on board when these guidelines have taken place. The authors of this guideline, they note that the chest pain remain a diagnostic challenge in the accident emergency department, outpatient setting, and obviously it requires a very, very thorough clinical evaluation. It is concerning to the patient as well as the physician involved in the care of the patient. The lifetime prevalence of a chest pain in America, at least, is nearly 20 to 40%. And unfortunately or fortunately, the women experience the symptoms more often than men. And the unique quality is that of all the people who come to the chest pain, few of them will have acute coronary syndrome. So all the extended emergency department presentation with the chest pain, only 5.1% will have an acute coronary syndrome, and more than half of them will ultimately be found to be non-cardiac causes. Having said that, one of the most common causes of death or critical outcome which can occur is a patient with acute coronary syndrome, which is discharged from the emergency department, having that this is non-cardiac, and such a patient suffer catastrophic complication somewhere down the line. So all the physicians involved in the chain of the patient care, from the nursing care to the physicians in the emergency department, they have a very heightened awareness that they should not really miss a chest pain. And this is a problem for the cardiologist. We keep on getting calls in the middle of the night. So the society in the documents, they start with the basic question, what do you mean by chest pain? So they say that defining chest pain, the chest pain is a common word which is used by patient and also applied to the physician to describe an unpleasant or uncomfortable sensation in the anterior chest that prompt the concern for a cardiac problem. So this is our typical definition of chest pain. And the society, the first most important top 10 take point of the American College is that a chest pain means more than the pain in the chest. The society wants us to emphasize and say very clearly, it means the pain, pressure, tightness, discomfort in the chest, shoulder, arm, neck, back, upper abdomen, jaw. So it's pretty comprehensive. And not only that, apart from the pain, the society also says that we have to actually look for shortness of breath and fatigue, and all should be considered as anginal symptoms. The chest pain should be considered stable when the symptoms are chronic, associated with a consistent precipitant such as exertion and emotional stress for him. So it appears that this society guidelines are kind of a little bit broad. You have to just not look at the chest pain, but the associated symptoms also. And for this, we come to a very, very important story, which all of us, many of the people know, is about Clinton, who was the 42nd president of America, and this was some time back. And he had a bypass surgery in 2004. And this is the scripts from the statement which he gave to the press over the time. He said very clearly, he had one message to the public: don't ignore a body, because he said very clearly that the warning signs of heart disease became long before he had a quadruple heart bypass surgery. And in one of the statements, he said that I used to work with a trainer. So this man was also interested in fitness. He had a trainer. He was the president for 8 years till that we developed Amai. So those trainers were tracking him and he was getting trained. He said, still, when I would go out for a run, after a mile, I have to stop and walk 100 yards and 200 yards to get my breath, and then I could run again. So this is a classical symptom. The symptoms come, they are relieved by rest, and they also provoked by exertion, and sometimes you can have a breakthrough angina. In addition, he said one very important thing in the interview in Good Morning America. He said that it is not the only signal where your chest is hurting so bad that you can hardly stand up and you're on the verge of heart attack. He said this is not just a chest pain. There are sustained shortness of breath, inability to do things which you are used to. So one of the things we should ask the patient, is the symptoms have become less or the symptoms are there? It is because the symptoms have genuinely become less, or is the patient has actually decreased the activity, or so inability to do things and he has decreased the activity, so the symptoms are more tolerant. You cannot really assume that it is the aging process. Clinton's continued, I just missed it. It was my fault. I don't blame my doctors or anybody else. Alhamdulillah, I did not blame the doctors, and I was insufficiently vigilant. So it appears there's a spectrum of the patient for the chest pain. We have on one side a typical pain, which is central pressure, squeezing, gripping, heaviness, tightness, which even the MBBS student will recognize. On the other hand, we have pains which is sharp, fitting, pleuritic, and positional, which you will recognize as non-cardiac. But the patients don't come in the extreme. These patients have a huge spectrum. We start from the left side of the bar and go to the right side. And a patient with coronary artery disease or suspected chest pain can lie anywhere in between. And particularly in the Middle East, where we are so much careful about the medical ear problems, eventually all the patient will go down the diagnostic pathway for them. So another thing which the European society disagreed with the American society. So the European society was having this three terminology in the practice: what is typical, what is atypical, and what is non-anginal chest pain. The European Society in the paper, they said that since studies published in 2015, they said that majority of the patients suspected to have coronary artery disease will have atypical or non-injural chest pain, which only 10 to 15% presenting with a typical chest pain. So a couple of decades back, a lot of patients have typical chest pain, but now we have modified the disease process of coronary artery disease by using aggressive medicines, by using lipid-lowering medicines. So the pattern of coronary artery disease is changed. Most of the people with the heart-beating diabetes and hypertension, over the time, they receive disease-modifying medications. So there's a constricting pain, which is in the front chest, a typical location, peripheral exertion, and relief by rest or nitrates within 5 minutes is a typical pain. If you have 2 or the 3 features, it means atypical pain. And if you have none of these features, you have the non-anginal pain. The American colleagues in their paper, they said this terminology is outdated and we should not use any more terminology. The reason is that when you say atypical pain, most of the people they imply this pain is actually non-cardiac. So they are one of the top take-home messages by the American Society is that non-cardiac is in and atypical is out. If you suspect that this pain is not suggestive of angina, please don't label it as atypical. It's a common thing in the clinical practice. We label everything as atypical. Non-cardiac should be used when the heart disease is not suspected. Atypical is a misleading description of a chest pain and the use should be discouraged. The chest pain should not be described as atypical. It is not at all helpful in determining the cause. So the American people, they say we have 3 terminologies for the chest pain: cardiac, possibly cardiac, and the non-cardiac. And this is a class 1A recommendation. Anything which is you said think is respiratory, gastrointestinal, chest wall, and psychological should be labeled as non-cardiac. Another thing which the authors highlighted is the changing nature or the changing profile of the patient with a stable coronary artery disease. They note that, like we told you, like we discussed before, there is a change in the pattern of stable coronary artery disease. And we tell our medical students, our colleagues who are coming there, this is the pattern of stable chest pain. But this pain prevalence has become extremely low. Typical exertional angina prevalence is generally low, and how low is less than 10%, with more patients presenting without the classical demand-related symptoms. Symptoms can be infrequent, not necessarily symptoms should be there a couple of times a day. Some patients have symptoms on weekly and monthly basis, which challenge the diagnostic evaluation, particularly because patients are aware and they actually decrease their activity threshold. Further, they said, among the patient undergoing diagnostic evaluation, there is a relatively low prevalence of obstructive coronary artery disease and ischemia, as low as 10%, and the last decades have witnessed a steady decline in the prevalence of obstructive coronary artery disease. Current testing pattern, which is advocated by all of us, and it is actually good for the business, our business as a cardiologist, has got a high normal coronary angiography rate, upward of 50 to 60%. It appears that we have to have more tests because the imaging technology has changed dramatically over the time. So over these years, there is a challenge, there are changes in the diagnostic abilities and the chest pain evaluation. And these changes occur at multiple levels. For example, like our colleagues will show in the subsequent talk, there have been tremendous advances in the therapeutic and the diagnostic methods over the last few decades in the PET-CT scans, in the CT-FFR, and so on. But in the clinical practice, at least in the area which I work in, and my colleagues and the people around me and myself also, the standard diagnostic strategy has remained unchanged for decades, and they have remained unchanged from the time we left our fellowship, and they are kind of ineffective in selecting patients for invasive coronary angiography. Contemporary cohorts of patients which in clinical practice are lower risk with low event rate and fewer obstructive coronary artery disease. So there is actually a lot of hazard in the patients in this population. So the guidelines which came in 2012, and these were the American College of Cardiology guidelines which came in 2012, they have kind of become outdated strategies, and these guidelines are focused in detecting the patients which require invasive coronary angiography to detect obstructive coronary artery disease. So this is now given up. And also the concept in American College Cardiology 2021 guidelines about coronary artery disease has changed. For example, historically, we tend to say obstructive stenosis when the patient coronary artery stenosis crosses 50%. So, and anybody less than that, we will say this minor coronary artery disease or this non-obstructive coronary artery disease. But the current guidelines are saying that terminology, very clear terminology, that use that no plaques or no coronary artery disease for those people who have absolutely no plaques in imaging. And if anything above 1%, even a coronary plaques should be labeled as coronary artery disease. And the cutoff between obstructive and non-obstructive is 50%. If it is 50% or more, you tend to say this is obstructive coronary artery disease. Anybody between 1 and 49% is non-obstructive coronary artery disease. So how do we approach a patient in our population? We can actually divide them in those patients without coronary artery disease known and not known to have coronary artery disease. So first I will take the category who don't have coronary artery disease. These are the patients with who come to clinical practice with no background of coronary artery disease in the patient. It is possible they have a family history and they come to to have a stable chest pain. These patients present a dilemma. They are young people, sometimes they are 30 years old, they are 25 years old, refer from anywhere in the world, from the general practitioners, from their work colleagues inside the hospital. And the dilemma for the cardiologist is that should all these patients be tested regardless of the likelihood of having obstructive coronary artery disease? Shall we do the justice in which everybody has to go to the diagnostic pathway and we exclude coronary artery disease? Obviously, this procedure is a good procedure, but subjects the patient to hazard and is actually not very cost effective. So we have to have some selection process. How we can safely select patients for not testing? How we can divide among the patients, which are the patients we can safely discharge home and not to worry at home that this patient will come back to the ER after some time with an acute coronary syndrome for him. What method we use, what type of pretest probability we use. If you use a pretest probability, what should be the cutoff having coronary artery disease? 5%, 10%, or 15%? Should we use any risk modifiers to refine patient selection for testing or not for testing? So the European Society in their 2019 paper, when they came out with the guidelines, they actually used the contemporary data from 3 clinical trials which were put together, and a paper was published in 2019 in the European Society of Cardiovascular Imaging, trying to look at the pretest probability. These are contemporary data, and the authors were astonished to find that the incidence of obstructive coronary artery disease in the population has decreased dramatically over the years. So the old pattern of classification, which was 1979 paper, was no more valid in the current population, which is currently prevalent in the world. And they found that we can divide the patients into typical, atypical, non-anginal, and obviously they also include the word dyspnea. And in this population, depending on the age, this does not take into account the risk factors, only talks of the age and the pattern of the pain. Anybody which is green segment more than 15% requires further attention, and anybody which is with the gray or light green section, which is less than 15%, they say this is less than 50% has got low probability of having coronary artery disease for him. So the European guidelines note that the studies have shown that outcome in patient classified with a pretest probability of less than 15% is good. Good means the annual risk of cardiovascular death or MI is less than 1%, and hence the guidelines recommend it is safe to defer routine testing in patients with a pretest probability of less than 15%, thereby reducing unnecessary procedure and the cost. And so what do they recommend? Calculate clinical pretest probability. These charts can be pasted, put on the wall, can be carried in the mobile. Do not routinely test patients with a pretest probability less than 15%. And if you are still suspicious of having coronary artery disease, you can actually use some amount of modifier to refine the pretest probability. And what type of modifiers they consider? They consider 2 types of modifier. One is calcium scoring by CT scan and by doing an plain exercise ECG. If these things are negative, this makes the chances of having coronary artery disease pretty low. And if the coronary calcium is positive, this makes the chances of having coronary artery disease a little bit on the higher side. And we are going to have a special talk with Dr. Safa in this matter somewhere down the line after my talk for him. So what about this one, American quality people? The American people also say a similar saying that if you have a patient in the clinical in the patient with a stable chest pain and not known coronary artery disease, a model to estimate pretest probability is the one which is needed. And this also they gave us as a class 1 indication for him. The American people also note further that the older pretest probability score, which was based in 2012 guidelines and the guidelines before, they were based on the Diamond Forrester study, which came in 1979. This, if you apply this Diamond Forrester model to the current population, which is prevalent around us, results in the significant overestimation of contemporary patient referred for non-invasive imaging except women. Hence, it is preferable to use contemporary estimates such as published in last 10 years in preference to score from historical patient series. And obviously, this contemporary series estimates, they estimate the coronary artery disease much less than the older population. They also note the major strength of the new models is the extensive validation in the different hospital settings and the countries. And they also highlighted the European Society table. They said another updated model was to estimate the pretest probability was recently developed and is recommended by the European Society. So they refer the 2000 paper, further reinforcing the fact that the prevalence of obstructive coronary artery disease is substantially lower than predicted estimate. Then whenever is available, again, we come to the point of calcium artery scoring, that whenever the information on the presence of the amount of CSE may be useful to enhance the pretest probability of coronary artery disease, the CSE can be estimated by doing a dedicated CSE scan or from visual estimate of the CSE based on the prior non-cardiac CT scan done. And the table they recommend is the same table, similar table, but modified by the American College, that these are the boxes with the green and the orange. For the light green, no need for testing. If you have a dark green, whether you have chest pain or dyspnea, this patient, they require further workup. And the cutoff they use is 15% once again. And like you say, this band is the band on the base on the clinical background. But if you use calcium artery scoring, the band can becomes more precise and you have more discrimination with the point. 15%, absolutely no need to do any test in the general population. And the American people, they say, calculate clinical pretest probability. Do not routinely test patients with the pretest probability less than 15%, the class 1. And among this subset of patients, calcium artery scoring is considered as to be a regional first-line test. This is a class 2A recommendation. So when you do all this testing, you can divide the patient into low risk and not at low risk, which is actually intermediate and the high risk. If you have a patient with a low risk patients, the American College of Cardiology recommend, if you want to look further, calcium artery CSE testing and exercise testing. So calcium artery scoring testing is reasonable at the first line treatment, and both these have received 2A recommendation from the American College of Cardiology. If you want to do exercise testing, it is a plain, simple exercise ECG, provided the person can cross a substantial level exercise. And this exercise level, they are saying, as it should be around 5 minutes or more. So what about the patient who have intermediate or high risk on the pretest probability? So if you have somebody with the intermediate high risk on the pretest probability, the approach to the diagnostic evaluation, and this is the synopsis of the American College of Cardiology, they said that the patient with intermediate high risk patients have a modest risk of obstructive coronary artery disease. And this, when you say a modest rate, we are talking about not 1 or 2%, we are talking about 10 to 20%. And the risk of clinical even exceeds 1 to 2% per year. In the old guidelines of 2012, these patients were targeted for invasive coronary angiography. So the previous guidelines supported the direct reflow of invasive coronary angiography in such patients, but the current guidelines, they recognize that contemporary randomized trials support these candidates may be safely tried using CCTA, so the coronary artery angiography, or non-invasive stress testing. The approach should be guided by the ability to achieve high-quality imaging and the local availability and the expertise. So obviously, this differs from hospital to hospital. And so this is the algorithm. They say, irrespective of the test performed, the overarching goal for the cardiologist and the clinicians in the clinical practice is to identify patients who will derive from guideline-derived medical treatment. Mind you, these patients are not the patient with the coronary artery disease. These are de novo patients without any coronary artery disease, and they have been found to have high risk on pretest probability. So the first step is to use them to modify the lifestyle modifications, to look at the risk factors, control the blood pressure, to bring the cholesterol down to the levels which is appropriate for the patient age, sex, and the disease profile, and to use the 2019 preventive guidelines. And if somebody wants, they can use the European 2021 preventive guidelines for him. So in this patient, what do the guidelines recommend? In this patient, these are all very complex slides. So I've just put a box at the back. They say CCTA and the stress testing are both class 1 indication. And we are now going to discuss more about imaging because we have a lot of talks coming on imaging. But the recommendation is that you can choose the either option. If you choose the stress options, they say you can use stress echocardiography, PET, SPECT, NPI, or CMR. And among them, they recommend PET over SPECT. So the PET scan is recommended over the SPECT. SPECT we have in Future Hospital available. We do the PET scan because to improve the diagnostic accuracy and decrease the rate of non-diagnostic test. Further, they also recommend 2 more things. For intermediate high-risk patients who have no coronary artery disease and interpretable ECG and able to exercise, they said even you can do exercise electrocardiography, and this is a class 2A recommendation. And if the intermediate risk patient, you are doing a SPECT imaging, then they say because the SPECTs are prone to artifacts, time and again we get a report of the nuclear medicine department, the inferior basal is having ischemia, and they do angiography, we find that everything is normal for him. The use of attenuation correction or the prone imaging may be reasonable to decrease the rate of a false positive for him. So how do you choose between the two imaging technology we discussed, the CCTA or the stress for him? So they say very clearly, if you are a patient with intermediate high risk and you are actually thinking to which imaging to use, which methodology to use, we have a methodology of anatomical imaging and we have methodology of functional imaging. You can choose CT choreangiography for those people who are less than 65 years of age and not on optical perimeter therapy. And the reason is that it gives you multiple information, more just the status of coronary arteries. It can talk about anomalous coronary arteries. It can look at the aorta and the pulmonary arteries. And if somebody is more older, the likelihood of coronary artery disease is much more high. It is better that you can do a stress imaging. So you can use stress echo, you can do stress CMR, or you can do stress PT, or you can do SPECT scanning in this patient. And these have not only the advantage of this test is that it can give you information regarding the scar, especially if you use PET scanner, CMR, and it can even help you to look at the coronary microvascular dysfunction. So these are the recommendation which is given by the American College of Cardiology. Then what imaging, stress imaging you will use in the population? The guidelines, they say that it all depends on local availability and expertise, depends on the patient characteristics and the contraindication, and the shared decision making to be encouraged. We have to remember that coronary CT involves radiation, it involves the contrast. Some people may have borderline renal functions, and it may be a good idea in those patients to use the stress imaging because they are kind of more safer on the kidneys. So they say that the exercise stress testing is preferred over pharmacological stress. If somebody wants to stress, don't give them dobutamine or don't give them adenosine. It is better to do exercise stress testing. PET preferred over SPECT. So the PET scan is preferred over SPECT. This is class 2 recommendation. And we have a separate lecture on obese, so I will not talk. So imaging obese patient is much more challenging, and we will hear more about obesity imaging somewhere down the line for him. What about another thing? They said everybody should have a routine transthoracic echocardiography. So I think this is, we all follow, whether they are low risk or high risk, the patient in the clinic immediately will get an echocardiogram. And this is very, very important. This becomes a class 1 indication if you have pathological Q wave, if you have heart failure, if you have complex ventricular arrhythmias, or if you have a patient clinical murmurs, because it can pick up other non-cardiac causes of chest pain, not cardiac, but not non-coronary causes of chest pain, such as aortic stenosis or pericardial abnormality or valvular abnormality. So what happens if the index test is negative or is positive? So then if the anatomical index test results are positive or inconclusive, I will not at all go into details of this one. If it is very easy, if it's normal, if it's extremely normal, obviously you will send the patient to invasive coronary angiography for him. But the problem is that most of the patient will lie in between. They will not be normal and they will not be grossly abnormal. In that patients, we have some recommendations, and we will get more elaborative talk about this down the line. In this case, if you are using anatomical modalities, we have now advances in CT angiography that we can actually look at FFR CT, and the FFR CT can actually identify the artery, can identify the significance of the lesion, and tell us without doing coronary angiography, do we have to do something for this lesion, or we can just leave on medical terms. If somebody chooses and stress imaging as the index test for the functional imaging as the initial test for him, then if it is moderate to severe ischemia, then obviously you can think about invasive coronary angiography. And if you decide to do a medical treatment, you can continue peripheral therapies in this population. So what is the last category which we look is the stable coronary artery disease, stable chest pain with a known coronary artery disease. Now, this is a very difficult because once you label the patient known coronary artery disease, he's got obstructive coronary artery disease, he become very much sensitive. So if any problem, he comes to the hospital and the doctors become very aware that there's an obstructive element. When we say obstructive, you're talking about lesion more than 50% or more than 50%. So we also have a heightened awareness. So anything in the chest is interpreted as angina. In this population, the important initial steps as recommended by the society is that for patient with obstructive coronary artery disease and stable chest pain, it is recommended to optimize guideline-derived medical treatment. So if you know there's obstruction inside the coronary arteries, which is more than 50%, you optimize guideline-derived medical treatment regarding the blood pressure, regarding the lipids, regarding the antiplatelets, and regarding the anti-ischemic therapy. Those we don't have non-obstructive coronary artery disease and stable chest pain, it is recommended to optimize primitive therapies. The guidelines also notice that the clinician should opt for guideline-derived medical treatment for obstructive coronary artery disease, but there are no current guidelines which are specific for non-obstructive coronary artery disease. And for these people, you have to use atherosclerotic cardiovascular prevention guidelines as the fundamental therapy or the basis of a treatment for him. For those people who have the stable chest pain and known coronary artery disease, and they have a frequent pain and they have a high-risk pain, then obviously all of us in the room will agree such patient should go for invasive choreangiography. So this is the invasive choreangiography. If you do invasive choreangiography, the guidelines nowadays recommend FFR in most of the patients. So FFR will avoid to do intervention in many of the places. Visually, we may think the lesion is significant. The FFR may turn out to have a different picture altogether. And if somebody is having previous coronary revascularization, which is the last part of this table. So in patients who have stable chest pain with the previous coronary revascularization, the guidelines recommend you can actually choose coronary CT to evaluate stent patency for the stents which are more than 3 mm in size. The CT angiography is pretty good, or evaluate bypass graft if somebody is underwent bypass surgery for him, bypass surgery. What about those people who have an obstructive coronary artery disease, but the pain is not frequent pain and the risk is not high? In this case, you can actually think of doing stress for him, and the methodology is same. You can use stress, the PET, SPECT, and CMR or echocardiography, and this is again class 1. And again, once again, the guidelines say it's a 2-way recommendation to choose PET over SPECT in such patient if you use functional imaging in this population. So another subset of patient, which is difficult patient, which has become less because nowadays we don't use bypass as much as we used to use 20-25 years back. What about the patient with a pure bypass who have chest pain? We know from the CAS study that patient with bypass, they have a T-shape of the grafts, and typical CAS data is that in first 1 year, 10% of grafts become occluded, and there's a 5% graft occlusion for the first 5 years and 10% graft occlusion subsequently between 5 to 10 years. Although the lemma have a longer patency, so they say that in this population, invasive choreangiography or a stress testing is both can be useful, and the invasive choreangiography is recommended for guiding therapy decision. This is class 1 recommendation. And but they said before you go to invasive choreangiography, it is always better to do a stress imaging or a coronary CT, because you want to see how the lesion has progressed. It is possible that patient is having pain and the CT choreangiography and the stress is totally negative. This patient should be put on medical treatment alone. But if the stress of CT is positive, then you have to do invasive coronary angiography. So this is a recommendation by the society guidelines which are seen for him. Then what about those patients with a non-obstructive? Now, this is the most challenging patients. A non-obstructive coronary artery disease can be just as 1%, 2%, just a plaque, or can be even more higher up to 49%. In this patient, when the patient comes to us, the first thing which comes to our mind is to know is there is a progression of coronary artery disease. So the society in the paper, they notice that atherosclerosis is a progressive disease that worsens over time with the non-obstructive coronary artery disease, consistently identifies as a precursor of acute coronary syndrome, and they note in the PRIMUS trial non-obstructive coronary artery disease at a 3-fold increase in the MACE event over 2 years follow-up. Additional analysis of the Scott Hart and the PROMISE trial revealed that high-risk atherosclerotic plaque features, that is softer plaque, the plaque with a more lipid burden, are associated with an elevated MACE among the patient with a non-obstructive coronary artery disease. And that is how we are now shifting toward the plaque modulation by the lipid lowering. And this is a separate topic by itself for him. So the first step is to determine the progression or the significance of the non-obstructive coronary artery disease. So the guidelines, they recommend you should subject this patient to CCTA if it is possible. And if you do a CCTA and you find stenosis between 40 to 90% on CCTA, then it is good idea to subject this patient to CT-FFR, so this non-invasive FFR. We don't do it in our hospital, but I'm sure we will hear more about this somewhere down the line. So the CCTA, they note, can further define compositional alteration between the plaque, such as the non-calcific plaque and the positive remodeling. They note, the societies note, that the low attenuation plaque burden has more than 6-fold increase in the incident MI for the patient with non-obstructive coronary artery disease. Further, FFR CT is very, very useful, and the societies note that even FFR CT is even better than invasive FFR. So the FFR CT improves diagnostic accuracy over and above obstructive CAD on coronary angiogram when compared to invasive FFR. And this was showing in the advanced registry where FFR CT changed treatment recommendation in 2/3 of patients. And when the recommendation was followed after changing, there were no adverse event at 90 days for patient with a negative FFR. So these patients, some of these patients are classified as INOCA. So this patient who experience ischemia or non-obstructive coronary artery disease. So if you have non-obstructive coronary artery disease and do a functional imaging and you demonstrate ischemia, so this patient can be labeled as INOCA. and they say that in such patient, it benefit from assessment of functional significance of intermediate stenosis, and that is where the role comes for stress imaging for the PET, SPECT, CMR, and ECO is reasonable for the diagnosis of myocardial ischemia. If you suspect INOCA, then obviously you have to look for further testing, and this has borders in invasive testing, because the invasive assessment is more comprehensive and the non-invasive testing is more prevalent. So we tend to use non-invasive testing because the previous CT is having borderline, but it's a female patient and they have a frequent angina, and you do a non-functional testing and you find invasive ischemia. So you would actually correlate the two. In that case, it is a good idea to do a non-invasive testing, to do an invasive assessment for him. And the invasive assessment, if you do, it requires to have a confirmed that the patient have an FFR, CT FFR of more than 0.8 and the evidence of ischemia on a functional imaging, and I will not go into it more. And if you do a stress CT or cardiac MRI, you can actually look for certain other parameters, which we will hear somewhere down the line. If we can look at the myocardial blood flow reserve, so MBFR, and if you do a stress echo, you can actually look at the coronary arteries and you look at the coronary blood flow reserve in the proximal coronary artery, but just by doing a stress echocardiography, provided your machine resolution is good for him. So, ladies and gentlemen, with this, I nearly come to the end of the talk by saying that the typical exertion angina prevalence is generally low, is as low as less than 10%, with more patients presenting without the classical domain type symptoms. The last decades have witnessed a steady decline in the prevalence of obstructive coronary artery disease. Among the patients who undergo a diagnostic evaluation, we are happy to tell the patient that we did a checkup for you and everything is normal. So there's a relatively low prevalence of obstructive coronary artery disease, less than 10%. Many centers have a high normal coronary angiography rate, upward of 50 to 98%. In our centers, it's probably 15%. We have a normal angiographic rate. One need to use judiciously coronary CT or stress imaging, or both, depending on the availability and the local expertise. And this one diagram, which the American College had given in the table, is pretty useful. So you have to risk stratify by using pre-test probability. If somebody is asymptomatic, just do no testing, do a lifestyle modification, address the risk factors. Somebody is having a low risk by pre-test probability and there is a chest pain, then in that case, these two categories, the societies recommend no testing. And if you want to do some testing for the low risk, you can do an exercise ECG, or you can do a calcium artery scoring for the proximal coronary arteries. And obviously, as you go up down the pyramid, from we change the category, intermediate risk, high risk, we need some form of analytical or functional testing. So with this, I come to the end of the talk, and thank you very much for your attention.
Thank you so much, Dr. Amrish, for this comprehensive overview. Really summarized the nuts and bolts of stress testing and chest pain evaluation. And this was a very nice, thorough summary of the ACC/AHA guidelines. There are a few questions, but we'll hold them till our panel discussion. It's my pleasure now to introduce the second speaker, Dr. Safa Al-Mihdar, who will be touching on a really controversial topic, which is the role of coronary calcium testing in symptomatic patients with stable chest pain. Dr. Safa, the floor is yours.
So good evening, ladies and gentlemen, and thank you, Firas, for inviting me to be part of this interesting webinar today. And I will be trying to address the question of the role of coronary calcium as a first-line test in chest pain evaluation. I just need to set myself here up. Can you see me?
Yes.
Hello?
Yes, we see your slides.
Because I cannot see myself, and I just once again. Okay, so if we start about talking about So calcium scoring is a non-invasive imaging modality that has been developed 3 decades ago by Agatston and its group in order to quantify a calcified plaque burden in the epicardial coronary artery disease. And it has been really extensively studied in the asymptomatic group of people for primary prevention of atherosclerosis cardiovascular disease. And coronary artery calcification has demonstrated its superiority over risk factor-based paradigms such as the Framingham risk score. And the quantification of calcium scoring has become not only useful in detecting clinically significant disease, but also discovering its absence is equally important. And I will try in this presentation to highlight the importance of having a calcium score of 0 in symptomatic patients. So when you quantify calcium scoring, basically it gives you the glasses and lets you see directly the presence of coronary artery disease. So coronary artery calcification is simply equivalent to coronary artery disease. And it helps you to indirectly quantify atherosclerosis plaque burden. And when I say indirectly, it allows you to see only the tip of the iceberg, but however, it correlates quite well with the true burden of atherosclerosis plaque. And it can be assessed quite nicely by coronary artery calcification, which is really turned to be the best predictor of cardiovascular events, even better than other known risk factors, age and sex. And this has been supported by an extensive stroke evidence data by large population-based studies with long-term follow-up, such as the MESA study, Framingham Heart study, as well as the Rotterdam study. And we know that from earlier on studies back in 2007 by Bidoff and his group, that the higher calcium that you have, the higher your risk. So having a calcium score over 100 increases your risk of cardiovascular events by 10 times. Having a calcium score of more than 1,000 increases your risk of events by 60 times. And really it stands out beyond other traditional risk factors such as diabetes, hypertension, smoking, and dyslipidemia. If we look at this graph from the MESA study, looking at the x-axis, you can see the traditional Framingham risk scores. In the y-axis, you can see the event rate, and in the z-axis, you can see the calcium score. And you can see that the presence of high calcium score burden, even among individuals without any risk factors, is associated with an elevated event rate, whereas absence of calcium score, even among patients with many risk factors, is associated with a low event rate. Calcium score also stands well against other vascular markers such as the intimate carotid thickness, BNP, CRB, and other indicators. It's a very simple test to do. It's technically easy. It has a well standardized protocol, and the interpretation is easily done by a software. It's a scan that requires no contrast. It's widely available. It requires a very short breath holds of up to 5 seconds. And if you do a dedicated calcium score scan, you don't need any beta blockers. The radiation dose of calcium score has tremendously reduced owing to the development of both soft and hardware, and it's actually less than having a mammogram. The standard method of quantification is the Agatston score, and also you can estimate the presence of calcium score in non-cardiac scans. You quantify it as having a no calcification or a calcium score of 0, minimum calcification if you have a score up to 10, mild calcification if you have a score of 100, moderate calcification up to 400, and extensive coronary artery calcification by having a calcium score of more than 400. Calcium score really helps you to reclassify your patient's risk. It shapes the diagnostic pathway and it plans your therapeutic strategies. It helps you to decide if this patient really need a statin or aspirin, making it a cost-effective test and also helps your patient to adhere to treatment. But more importantly, what does calcium score do is really de-risking patients, used as rule-out method, used as having a calcium score of 0. And this comes to the principle, can we use that in symptomatic patients? And can we really invest into the power of having a calcium score of 0? And which really has been shown in multiple studies in the primary prevention group that it gives you up to 15 years warranty period of very low risk of cardiovascular event. So having a calcium score of 0 functionally de-risk the patient to a lower risk category for future cardiovascular events and mortality. And it is one of the strongest negative risk markers, as I just shown, for having events in the next 15 years. So can we use it as a gatekeeper in symptomatic patients who comes to you with chest pain? This is some of the studies that really evaluate the power of 0 in symptomatic patients who underwent coronary CT, presented with chest pain and had calcium score of 0. And you can see a very low percentage of events in the follow-up. So does a calcium score of 0 means no plaque? We know this is not true, as we have different types of plaque. We can see the calcified plaque, where it gives you a calcium score, and the non-calcified plaque, where it gives you a calcium score of 0. This is one of the early studies in 2012 addressing the patients with chest pain and try to understand what does a 0 calcium score means. So they looked into over 2,000 patients age 58, plus or minus 10 years, half men and half women, who underwent a 64-slice cardiac CT due to chest pain. And they found a calcium score of 0 in around half of these patients, 470 men and 640 women. And of those people who have calcium score of 0, they found obstructive coronary artery disease in 48 patients. That was around 4.3%, 35 men and 13 women. And among patients who have a calcium score of 0, men had a higher prevalence of both premature coronary artery disease as well as multiple disease. And they concluded in this study that a calcium score of 0 cannot be used by itself to exclude obstructive coronary artery disease in symptomatic patient referred for coronary CT. I will take you to this meta-analysis that has been published in JACC just a few months ago that looked into the prognostic value of having a calcium score of 0 among individuals who are presenting with chest pain in utilizing calcium score as a test to rule out obstructive coronary artery disease in symptomatic patients presented with both stable chest pain as well as acute chest pain of low to intermediate risk for coronary artery disease who went for coronary CT, and the database was collected from 2005 up to 2021, and the mean age was 50. So when they looked into the studies, they found 19 studies of patients with stable chest pain, and that really looks at around 80,000 patients, and 13 study in the acute chest pain category of around 12,000 patients. And the summary of their finding are as follows. Calcium score of 0 was present in around 50% of all patients with chest pain. Calcium score of 0 had the ability to exclude obstructive coronary artery disease with a negative predictive value of 97% in the stable chest pain group and 98% in the acute chest group. However, there was a small percentage of patients who had calcium score of 0 and have obstructive coronary artery disease, 33% in the stable group, chest pain group, and 4% in the acute chest pain group. So they concluded from this meta-analysis that looking over 92,000 patients with stable or acute chest pain, the absence of coronary artery calcification was associated with very low prevalence of obstructive coronary artery disease, low prevalence of non-obstructive coronary artery disease, and a low risk of major adverse cardiac event. And they propose that these findings support the role of calcium score of 0 as a gatekeeper for more advanced imaging among patients presenting with chest pain. However, they had some concern regarding some sub-analysis of certain age group, i.e. younger age group, as well as women. This is another study has been published in JAMA last year, looked into the association of age with the diagnostic value of coronary calcium score for ruling out coronary stenosis in symptomatic patients. We know that age is one of the strongest risk factors for developing coronary artery calcification. As we grow older, you are more likely to develop calcification. So this is a registry from west of Denmark, where cardiac CT is a quite common test to be done. It's around 24,000 symptomatic patients with a mean age of 58 that has been followed for 4.3 years. Half of these patients, or more than half of them, were female. And they found a calcium score of 0 in around 54% of patients. And when we look at the graph, you can see in the light blue is a calcium score of 0, and in the dark blue, a calcium score of more than 1. And if you compare the younger age group to the older age group, you can see there is a high prevalence of obstructive coronary artery disease among younger age group, especially women, compared to the older age group, where obstructive disease is associated with higher calcium score. And they found that that calcium score of 0 has a diagnostic value in ruling out obstructive coronary artery disease, which was age dependent. In symptomatic patients below 60, they found that a sizable proportion of obstructive coronary artery disease occurred with calcium score of 0 and was associated with increased risk of myocardial infarction as well as all-cause mortality. So they concluded that calcium score in symptomatic patients is best used in patients above age 60 years. And that really is true, then, in which we have to take coronary artery calcification and understand based on age, especially should be used in men above age of 45 and women above age of 55, because below that age, there is a risk of developing what is known soft or non-calcified plaque. What about women? This is a study, a pooled analysis from Promise and Scott Hart about looking into major adverse cardiac event in women, and they looked into if you look at the left graph, where is the red indicate a calcium score of 0 and blue a calcium score of more than 0, and they found that coronary artery calcification was not an independent predictor of MACE in women. And women with non-obstructive coronary artery disease on cardiac CT are more likely to have MACE, more than if they don't have any coronary artery disease. So this can be explained by the fact that usually women develop coronary artery disease 10 years later than men. And hence, women will have coronary calcification also later than men. Signs and symptoms of ischemia can happen in women with the principle of Inoka that has been highlighted by Dr. Agrawal as well, which is most likely caused by macrovascular dysfunction. And women are more likely to have Inoka and calcium score of 0. This is also analysis from the West Denmark registry, looking into the impact of plaque burden versus luminal stenosis. And if you look at these graphs, you can see the graph of calcium score of 0. Blue is having an obstructive coronary artery disease, red having non-obstructive coronary artery disease. And if you compare coronary artery calcification of 0 with higher coronary calcification, you can see that patients with comparable calcified atherosclerosis burden generally carry a similar risk for cardiovascular events, regardless whether they have obstructive or non-obstructive coronary artery disease. So the plaque burden, not the stenosis, not the luminal stenosis per se, is a major predictor of risk for cardiovascular event and death. And it's really, if you have no plaque, if you have very little plaque, or if you have even a very heavy plaque, having a calcium score of 0 is quite protective than higher calcification. So you have to use it in care in younger patients, and it can be used as a proposal to be as a rule in and not as a rule out test. What does the practice guidelines telling us? The 2013 multimodality appropriateness use criteria for the detection and risk assessment of patients with stable ischemic heart disease placed calcium score as rarely appropriate. The 2012 guidelines for the diagnosis and the management of patients with stable ischemic heart disease placed calcium score as class 2B. 2015 appropriateness utilization of cardiovascular imaging in the emergency department in patients with chest pain did not consider calcium score at all. And in 2013 ASC guidelines on the management of patients with stable coronary artery disease placed it as completely inappropriate test and give it class 3 indication. What about the latest 2021 guidelines for evaluation of patient of chest pain? And this has been extensively presented by Dr. Agrawal, but it's really a one of a kind of a guidelines that really address a symptom rather than a diagnosis. And if it tells you how challenging chest pain can be. And I will just highlight the main things that related to my topic. And this guidelines really did a major revision in evaluating patients with both acute and chronic chest pain. It really emphasized the importance of using clinical decision pathway and try to identify patient that is most likely to benefit from further testing, in which these patients, if being categorized as a low-risk patient, testing is being discouraged. And how can you use calcium score can be utilized very nicely in order to identify those patients that you can defer testing and these patients who will not need testing. And it states that whenever available, information on the presence and the amount of coronary artery calcification may be useful for enhancing the pre-test probability of obstructive coronary artery disease, placing it as class 2A. In the low-risk patients for obstructive coronary artery disease. Is there any true randomized control trial? Actually, there is 2 ongoing trials, the ACCURATE trial, the assessment of patients with suspected coronary artery disease by coronary calcium first strategy versus usual care approach. It recruited over 2,000 symptomatic patients to evaluate coronary artery calcification as a gatekeeper test, in patients who have a calcium score of less than 1 will be randomized either to have a PET-CT or medical management, and it will look into the cardiovascular outcome and cost effectiveness of this strategy, and the results will be out in 5 years. There is another study called the discharge study. It's a study that look at the diagnostic imaging for patients with stable chest pain and intermediate risk for coronary artery disease, recruited over 3,000 patients with stable chest pain and intermediate pre-test probability of coronary artery disease, comparing CT with coronary artery calcification to invasive angiography, and will be waiting for the results of these 2 studies. So to conclude, ladies and gentlemen, a calcium score of 0 effectively rules out significant epicardial coronary artery disease in low to intermediate risk symptomatic patient. The absence of coronary artery disease to exclude the absence of coronary artery calcification to exclude coronary artery disease in low to intermediate risk symptomatic patients appears promising given its exceptional negative predictive value. And there is an increasing amount of evidence to support the role of coronary artery calcification testing as a gatekeeper in low to intermediate risk patients with chest pain. and guidelines have yet to endorse the power of zero in symptomatic individuals. To summarize and to try to answer the questions that is the main topic of my presentation. So I just added that, is there a possible role for coronary calcium as a first-line test in chest pain evaluation? My answer and my humble view is yes, but we need to use it with caution in young age group, in women, and need to be used and assess the pretest probability of coronary artery disease. Is it ready for prime time? I think no. We still need further large randomized control trial to address this. Thank you very much.
Thank you so much, Dr. Safa. That was absolutely amazing and a very masterful take of a controversial and really a far from settled topic. I really appreciate your concise summary. So we are having more questions. What I'm gonna do next is to actually try to follow up my colleagues' amazing work and try to come up with just some. Let me just summarize. And try to come up with some take-home messages and see if try to put it all together and see how can we make sense of the different guidelines, the different data that were presented, and try to distill that into some take-home messages and practical pointers that we can use in daily practice. Do you guys see my slides okay? I have no relevant financial disclosures. So in the coming 10 minutes or 15 minutes or so, I'll try to touch on a few areas that have already been covered, but I wanted to emphasize on some of them a little further. Number one, how to optimize the yield of non-invasive testing in chest pain patients. And really dwell on how to choose modalities when deciding on which test to choose for the next chest pain patient you are going to encounter in clinic, and touch on some of the current guideline and societal recommendations, and perhaps briefly talk about whether we should be testing for coronary atherosclerosis or testing for coronary ischemia. Dr. Agrawal did an amazing job covering the chest pain guidelines, which is a really thorough and dense document for the first time covering a symptom rather than a disease. And the document has already been endorsed by multiple imaging societies, including the American Society of Echocardiography, Cardiac CT, and Society of Cardiac MR as well. So this figure has been shown. I just want to make sure that we are on this side of the graph where we are testing patients for a stable coronary artery disease. We're not talking about patients presenting in the emergency department with acute chest pain. And I think that one of the strengths of this guideline is, for the first time, they provide guidance when is it okay not to test patients, and when is it okay to defer testing. And Dr. Agrawal covered that pretty well by assessing and evaluating pretest likelihood for these patients and identifying subsets of patients in which or in whom deferral of subsequent testing is actually safe and recommended, and does not get the patient or the provider in trouble. So some of the PROMISE investigators actually tried to quantify this question and provide some risk scores to look at which patients in whom I can defer testing without penalty. When I say without penalty, without missing subsequent events and without any harm caused to the patients. And they came up with the PROMISE minimal risk score, and they really did a very intelligent type of analytic work, leveraging the data from PROMISE trial, and they looked at patients who did not have any abnormality. Everybody in PROMISE had chest pain, so they identified 25% of these patients who had symptoms but had absolutely no abnormalities on their non-invasive testing. And they also looked at the likelihood of having subsequent cardiovascular death and MI, and they came up with a score that comprises age, lower is better, female gender, excuse me, belonging to ethnic minorities, absence of diabetes, absence of hypertension, absence of any smoking history, absence of dyslipidemia, absence of family history, and absence of symptoms related to stress, physical stress or emotional stress. And the more you have of these variables, the higher your score. And if you score 10 out of 10 on the PROMISE minimal risk score, your likelihood of having a normal test is north of 70%, and your likelihood of having a severe abnormal test is less than 2%, and the likelihood of having an event is extremely low. So you kind of apply this, it makes sense and it's intuitive. You apply it in clinic. The absence of the high risk markers gives you a quantitative or a predicted probability of having a completely normal test before you order the test. And you can say that, okay, this patient is safe if I defer testing. And they put this online, the PROMISE risk tools, a very interactive format where you go online and you plug in the patient's age, gender, minority, etc., etc. Excuse me. The risk factors we discussed, and it gives you a predicted probability of minimal risk, meaning that this patient will have a totally normal study that you're going to order, whether it's CTA or functional testing, and the likelihood of having a cardiac event in the future. So this is a major change in the recent guidelines when it is okay not to test. And it's been really a challenge for physicians. When you see a patient, we feel compelled and obligated to do something to either to reassure ourselves or to reassure the patients. But here, using these tools at a larger scale will really optimize the yield of non-invasive testing for stable chest pain. Okay, so you have established and decided that this patient is not in the PROMISE minimal risk category, and I do want to test. So what should I do? So we've established that this is an intermediate to high risk patient with stable chest pain. What test should I order? So you have a lot of testing options available, and the goal is to try to provide you with some guidance by the end of this webinar, hopefully. So there are some tenets for test selection when you deal with chest pain. Your choice of initial testing should be guided by patient symptoms. As a 70-year-old male with crescendo angina needs to go to the cath lab. No, that's very different from a young female with likely non-cardiac symptoms. So the nature of symptoms dictates the first or the subsequent types of testing. Existing scientific evidence, we would like to always practice based on available data to guide not only the diagnosis, initial diagnosis, but also subsequent management, and hopefully altering a patient's prognosis. Available technology and local expertise. I cannot emphasize this point enough. If you have an experienced stress CMR laboratory, I can understand how stress CMR is the workhorse for non-invasive evaluation. If you have a busy and experienced nuclear laboratory, I can understand how that will be your go-to test also. But trying to alternate, or okay, I ordered 2 specs yesterday, I'm going to try to order more CMRs today. I don't think that is an appropriate approach, and you will end up diluting your experience and expertise, and you may end up with equivocal tests, and that will lead to suboptimal patient outcomes and layered testing down the road. So know the strengths at your facility and capitalize on them. Patient values and preferences. We oftentimes ignore these parts, but it is extremely critical to incorporate and involve patients in decision making and understand what is of value, what is important to them, and what are their preferences, what has been their previous experience with an angiogram, for example, or with a CT, or with a nuclear test. Incorporating that is extremely valuable. And it's extremely critical that you understand the strengths and the limitation of any imaging modality you're about to perform. So knowing that balance reduction in flow might be encountered when you deal with SPECT myocardial perfusion imaging is critical knowledge that you should have in mind before you routinely refer patients to nuclear testing, and so on. So you have to be aware of the strengths and the limitations of any imaging modality that you will rely on heavily and routinely. The guidelines this have already been mentioned by Dr. Agrawal, but I just want to emphasize a couple of differences in the wording. Number one, CTA, coronary CTA received a Class 1 level of evidence A recommendation as an effective tool for diagnosis, risk stratification, and guiding treatment decisions in patients with stable chest pain and intermediate to high risk. So diagnosis, CTA is a very sensitive test. If you see atherosclerosis, there is atherosclerosis. If you do not see atherosclerosis, then there is not atherosclerosis. A very sensitive test for diagnosis of coronary atherosclerosis. And the presence and the extent of plaque, some certain adverse plaque features have been associated with prognostic value. And also really we learned from Scott Hart trial that identifying atherosclerosis early on impacts therapeutic decision, and involves initiation of preventative therapies that translates downstream to improve patient outcomes. The language is slightly different, and the level of evidence is slightly different. There are two large randomized trials in favor of coronary CTA, but this level of evidence does not exist for functional testing at this point. So the level of evidence, recommendation 1 with level of evidence B for patients without known CAD, stress imaging is effective for diagnosis of ischemia and estimating MACE risk. There is no mention about subsequent decision because of decision and association with change in prognosis because of lack of randomized data in this space. There are a lot of observational data that shows that patients with greater burden of ischemia benefit from revascularization, but this evidence base is largely observational and retrospective. This is one of the seminal trials in this space, the PROMISE trial, a large study, 10,000 patients, looking at precisely the population we're talking about, chest pain, stable chest pain, randomized either to get functional testing, which can be any of the functional modalities, stress nuclear or stress echo or stress ECG, versus anatomic testing with CTA. And the patients were followed for 12 months, and there was no difference in the primary endpoint of death, MI, unstable angina, hospitalization, or major procedural complications. And there was also noted increased use of invasive revascularization in the CTA arm and increase in revascularization. So this is kind of similar to what we've shown. Similar outcomes whether you start with CTA or functional testing, but CTA is likely going to yield more invasive procedures and more revascularization without a net change in hard endpoints at 12 months. This is the second of the randomized trials in this space. The Scott Hart trial showing this is a study from Britain. Patients presenting with stable chest pain were randomized to either get standard of care, which in that part of the world is a treadmill test, or standard of care plus CTA. And it shows that patients who were randomized to CTA in the blue line had a substantially lower risk of coronary heart death from coronary artery disease or non-fatal myocardial infarction, with almost a 40% reduction in the risk of this endpoint. And the proposed hypothesis is that these patients will benefited from earlier initiation of preventative therapies, including high-intensity statins and antiplatelet medications. How do we put this together? This is taken from the European guidelines, and it shows a risk-based strategy for testing. Patients who are at the very low risk, it is okay to defer testing. Patients on the low to intermediate risk, coronary CTA may be appropriate or more appropriate in this group, whereas patients in the higher intermediate to high test, where the question is more nuanced and more complex, functional testing may be more appropriate, and so on. This is just a matrix shows some technical considerations, not really guidelines, but what patient characteristics would make you more or less likely to choose a specific modality. So if you know there is a patient with, for example, elderly, low exercise tolerance, an exercise-based study will be unlikely to beneficial, and you would want to consider either pharmacologic functional testing or CT angiography. A patient with a left bundle branch block or a paced rhythm, anything that increases the heart rate, you would want to avoid it. So exercise echo, dobutamine echo, exercise MPI should be avoided, and vasodilator SPECT or CTA are more appropriate. Obviously, patients with advanced kidney disease, CTA is something you would not go to first, and you may consider other modalities. Patients with AV block or high-grade AV block without a functioning pacemaker, you would want to avoid adenosine and regadenoson and the likes. Obese patients, echo-based modalities may be limited and challenging because of the limited acoustic windows. So nuclear and CT may be more appropriate, particularly if you have advanced techniques such as attenuation correction and so on. Patients who have AFib, especially if rate is uncontrolled, the CTA becomes more challenging. And similarly, patients with frequent ectopy, patients with COPD and asthma the use of coronary vasodilator should be monitored and careful. It's not a contraindication, but you would want to favor using regadenoson in patients who had severe COPD and recent exacerbation. And lastly, patients with prior PCI and CABG, you would want a test that not only tells you whether they have atherosclerosis, because you know they have coronary atherosclerosis. You want something that will guide management of therapy, particularly where to revascularize if needed, and so on. A couple of points, again, from the guideline. If you decide to pursue myocardial perfusion imaging with the radionuclide, PET is reasonable in preference to SPECT, and that has to do with the higher specificity, lower radiation exposure, and the ability to quantify myocardial blood flow, all of which are unique to PET, but are currently not available with SPECT. And there's also mentioned that you can use these modalities in a sequential way, meaning that if you have an inconclusive CTA, you can use nuclear or functional testing afterwards to clarify the results, and other way around. Just briefly touching on this a concept of if patients presenting with chest pain, we're worried about whether this chest pain is caused by coronary artery disease. So we're looking for coronary atherosclerosis. So why choose, if you can image atherosclerosis, why use a modality that measures the consequences of atherosclerosis? And this is more of a perhaps a conceptual discussion, but what are the modalities available for testing for atherosclerosis? CTA. However, most contemporary laboratories use hybrid imaging systems and can assess for atherosclerosis when performing SPECT or PET MPI at this point. It is not universal, but a larger proportion of labs use hybrid systems. This is not an option if you're doing a stress echo or stress CMR at this point in time, unfortunately. And the implications are significant. So if a patient comes to you with chest pain and he or she has a negative exercise echocardiogram, you tell them that your stress echo was normal, but you cannot make any statement as to whether or not they have concomitant atherosclerosis, which is really an opportunity to identify the disease early on and impact the disease trajectory forward. Assessment for ischemia there are more tools available. As I said, MPI, stress echo, stress CMR, and exercise ECG. The pros of atherosclerosis testing, it is reliable, it's very sensitive, it is prognostic, and it guides initiation of preventative therapies. Cons for atherosclerosis imaging, there is this category of intermediate or indeterminate coronary lesions where the technique does not reliably allow you to determine whether this is a 60% or an 80% and so on. And so unless you have adjunctive tools such as CT, FFR, and so on, you may end up in a kind of in a gray zone what to do next for these patients, especially if they have many of these lesions, and you may end up with requiring subsequent testing and higher downstream use of invasive procedures. On the other hand, ischemia evaluation is reliable. It's especially in the United States, it's widely available. It predicts MACE very reliably, and it probably has the largest evidence base behind its prognostic utility. And if you have access to PET, you have the additional advantage of being able to assess myocardial blood flow reliably as well. However, a vast majority or many of the laboratories continue to use non-attenuation corrected SPECT, which has low specificity and can also lead to subsequent testing. So again, this is more of a discussion of what is it exactly that you're looking for? Are you looking for atherosclerosis or for the consequences of atherosclerosis, and which test would be more superior? So, so as I conclude, you always want to tailor your testing strategy to the patient's likelihood of having epicardial disease. If it's very low, deferral of testing is appropriate. If it's high, you want to go directly to more invasive procedures. CCTA is a very effective tool, particularly for prognosis and for medication adjustment in ways that really translate into improved patient outcomes. Functional testing identifies actionable CAD in the sense that it identifies ischemia-producing CAD. How does that relate to changes in outcomes in the post-ischemia trial? I think this will require a lot of revisiting and perhaps readjusting our paradigm. And putting it all together, if you have patients, if you see a lot of low-risk patients, you may find yourself using more coronary CTAs. If, on the other hand, if you deal with patients, established disease, prior revascularization, who come back symptomatic, you'll find yourself relying on more complex modalities such as PET and SPECT. So with that, I will close, and I would like to invite my co-moderators to join the discussion and see if we have any questions in the panel. Okay. Any questions, any comments, Dr. Safa, Dr. Amrish, Dr. Hassan?
Actually, we wanted to elaborate a little bit and give us, because we in our hospital, we don't use any the functional, like advanced quantification regarding the imaging technologies of MRI and PET. If you can do some overview from Cleveland, that will be fantastic for us.
Was muted. Dr. Walid, how about I start with you and kind of use the next few minutes. When would you consider a stress CMR as a go-to test? I mean, what are the kind of 1 or 2 scenarios where stress CMR would be your favorite approach?
Thank you, Dr. Firas, and good evening, my colleagues. Actually, this is what I'm gonna to show in my case discussion. Actually, stress CMR is a very good alternative modality to CT and nuclear scan. In terms of sensitivity and specificity, they are all comparable. But in a specific case scenario, when I have to choose cardiac MRI versus SPECT or CT, typically, if I want to evaluate more than or beyond the coronary artery disease. So if I have a patient, I need to know about his cardiac function, for example, or myocardium or other valvular lesion, I think I will go for stress cardiac MRI, especially in patients with heart failure. So patient with heart failure, coronary artery disease is only one of the possibilities, but also myocardial disease, the second possibility. So if I want to hit multiple birds by one stone, I will go for stress cardiac MRI. But if it's only about coronary artery disease, then nuclear scan or CT, especially if no history of revascularization. Patient with established coronary artery disease or expected to have dense calcium score, like patient with chronic kidney disease, I will go for PET or MRI.
Fair enough. This is very helpful, very useful. Dr. Safa, any comments, any thoughts, anything to add in this regard?
It's muted, Dr. Safa.
Sorry. So what I just said is one of the important things is really looking into your local expertise and how comfortable are you in referring your patient to your colleagues to further evaluate patients. Again, as Dr. Amrish show in the guidelines, and as you put it all together, it depends on how you initiate and classify the patients into being low risk, moderate, or high risk, and also the question that has been addressed: is it purely coronary artery disease? Is it, would you think of myocardial disease? And it's a sort of a teamwork decision that you would really take and make a decision which test that you would move next.
Absolutely. Dr. Safa, there is a question that came in the chat box. How do we define, sorry, this is not the, which patient with a calcium score of 0 should have stress tests?
Okay, that is basically the summary of my presentation is when do you use a calcium score of 0 as a gatekeeper to where you can just comfortably stop and rule out coronary artery disease. Again, you have to start from the beginning. First of all, you have to risk stratify your patients and put that patient into either low, moderate, or high risk. So having a calcium score of 0 in a patient that I would say relatively old, above in male above 55, 45, or in women above 50, 55, and in the low category risk calcium score of 0, that might make me comfortable to stop there. However, still calcium score of 0 to rule out coronary artery disease has been well established in randomized control trial. In women, again, as I showed you, it will be a little bit tricky to make you sort of happy to stop there. And what I propose and what I would like to discuss and see your opinion and my colleagues' opinion in the category of younger patients, using a calcium score of 0 in ruling in instead of ruling out might be something that to consider. For example, if a patient have a higher calcium score of more than 0, then you would think further and test these patients. Having a calcium score of 0 will not make you comfortable in stopping there. So I don't know what you think of ruling in versus ruling out.
Dr. Amish, any thoughts or?
Actually, in our hospital, we are kind of more using calcium score we are using, but CT angiography from anatomical point of view we are using. We are not doing CT FFR. So I am just really was kind of thinking how the things are in Abu Dhabi. So we were keen of knowing.
Yeah, we'll respond to that, but trying to respond to Dr. Safa's comment. Dr. Hassan, any comments on using calcium score to rule in versus rule out for further testing?
Muted.
So thank you, Dr. Faraz, for giving me the opportunity. So I think with regard to that question, whether which patient should go for coronary for stress testing after having a calcium score of 0. So I would recommend that those patients who have certain other risk factors, and secondly the symptomatic status. If they are symptomatic, then they should go for stress testing even with calcium score of 0. And other risk factors like having strong history of premature coronary artery disease or multiple risk factor, smokers, so they might have non-calcified plaques.
Remember, all of this discussion pertains to symptomatic patients. This is all about symptomatic patients. Walid, I have a comment, but Walid, I see you have your hand up.
Yeah. So my personal experience, actually, I use a CT calcium score as a screening tool. So once the patient has symptoms, so I will go either for CTA or functional assessment. For me, CT calcium score negative in asymptomatic patients is still with a multiple, especially if multiple risk factors. Actually, I copy Hassan in this point. So if the patient has symptoms, even with negative CT calcium score is not enough to rule out patient with coronary artery disease, especially if he has multiple risk factors. So I will go for either CT coronary angiogram or functional assessment.
I guess this whole premise of pushing the envelope or trying to, we know the role of calcium in risk stratification for asymptomatic patients. The idea is, can we leverage this and push the envelope a little further and use it to triage symptomatic patients? So I would say in younger patients, in general, if you look at the totality of the evidence, in general, roughly, patients with calcium score of 0 and symptoms about 5% will have some degree of atherosclerosis, and about 0.5% will have obstructive atherosclerosis, roughly in that order. So in 200 patients with symptomatic with a calcium score of 0, you're going to have one who will have obstructive disease that you will miss. And I think the tempting role is to evaluate calcium in ruling out further testing rather than ruling in. We as physicians, we are very passionate about ordering tests and imaging patients and so on. So we already have a reason to image them, whether they have a calcium score of 0 or not. But whether we can use this information to avoid testing, I think that is the opportunity. That is where we can minimize and optimize the yield of the imaging modality. For some reason, we're not. The misses are higher in the younger patients, and we are uneasy about missing patients with obstructive disease who come to the ED, and we dismiss them and send them home. It's just we're uneasy, even though the diagnostic accuracy for SPECT MPI, for example, is 90%. We're happy to send a patient from the ED after a negative MPI, for example, on the chest pain unit days, even though the sensitivity is about 90%. So there's a 10% likelihood you may miss a patient with underlying coronary disease. Did that answer your question?
Dr. Firas, if you see the British guideline which came with stable coronary artery disease in 2016, they actually said in their statement that negative calcium score 0 has got no value, and it has got no value to exclude any. They don't recommend at all calcium scoring for assessment for stable coronary disease for chest pain. So it is good for screening, like you said. I mean, this is the British view, but the American, of course, they are talking about strongly. If you say the European and the American, they say if your pre-test probability is less than 50%, the one of the gatekeepers is calcium scoring.
I think most of us currently using calcium score as a ruling out test, not for ruling in.
In asymptomatic patients.
In asymptomatic patients, exactly.
Yeah, I agree with Dr. Safa's conclusion. It's probably not ready, and we're waiting for safety data from large RCTs. Dr. Safa?
Exactly.
Yeah, I think it was quite interesting topic really to search what is the data available, and my personal opinion is I will not really feel comfortable, to be honest with you, having asymptomatic patients with calcium score of 0 and telling him bye-bye, that's it. I don't think I will be happy to do that. I would further investigate that patient. Although now with the latest guidelines, it really emphasized the likelihood of deferring testing or stop testing. So let's see and wait for more studies and see if that 2A category will be uplifted.
Excellent. For the sake of time, Dr. Walid, we're going to go ahead and start with your case. No surprises here. You're very passionate about CMR, and you chose a case that highlights the role of stress CMR in evaluating patients. So why don't you go ahead and share your screen and show us your case, and we'll open it for discussion again.
Thank you, Dr. Firas. Sure. So we have a patient here today with multiple risk factor for coronary artery disease. He is 74 years old, was referred from another hospital for chest pain evaluation. He has family history of coronary artery disease, diabetic, obese, hyperlipidemia, hypertension, and he has irrelevant sensory neural hearing loss. This is his initial workup. The ECG looks normal, no abnormality, and this is his echo. It's normal. But the echo was reported as mild LVH. So this patient, according to the guidelines, his chest pain actually is mild to moderate, central, on exertion, with no signs of angina crescendo. So I decided this patient is intermediate likelihood of coronary artery disease. So I decided to proceed with non-invasive test. So I proceed with cardiac MRI. This is actually still images of cardiac MRI. I will show the video, the cine of the cardiac MRI for more information. So this is the cardiac MRI. This is the stress part. And you can see here hypoperfusion defect, pronounced mainly in the inferior wall, but also in the septum. Here you can see subtle subendocardial area of hypoperfusion. This is the stress images, and this is the rest. So the hypoperfusion defect in the inferior wall was completely reversible in the stress. Maybe subtle hypoperfusion also in the subendocardium in the septum, but in the inferior wall was completely reversible. And back to the slides. And when we did the late gadolinium, no evidence of a scar. Then we proceeded for angiogram based on the symptoms and positive stress test, positive cardiac MRI.
Well, can I stop you before you show the angiogram? And for those of us who do not look at stress MRIs like you do every day, can you walk us through what does this signify? How do you interpret this? And what is the correlation at an angiographic level?
Sure, Dr. Firas. So the stress MRI, actually, we use different modalities for the stress agents, adenosine, regadenosin for vasodilator stress MRI. Also, the vitamin can be used or treatment test. But for more practical cases, we use regadenosin in our center. So we do the stress first and the rest. And then what we're looking for, we look for hypoperfusion defect. So hypoperfusion defect, if it is present at stress and no hypoperfusion defect at rest, so this means that this is ischemia, provided that no evidence of scar. So if the hypoperfusion defect is found on stress and at rest with positive late gadolinium, I mean there is myocardial scarring, this is non-viable myocardial ischemia, is provided that it is in the distribution of coronary territory. So we are looking for hypoperfusion defect. We are looking at stress, then rest, and also we'll look for the corresponding late gadolinium enhancement. It could be true hypoperfusion defect for ischemia, or true hypoperfusion defect for myocardial infarction, or just artifact. So you've emphasized
subendocardial. Why is that important, and what does that correlate with from a coronary physiology standpoint?
As we know, the ischemia manifested more distally compared to more proximally. I mean, the first part of the myocardium that suffers from ischemia is the endocardium, as this is the more distal part suffering from ischemia. Then it should be manifested subendocardial, extending down the way to full myocardium, but also follow a specific territory distribution of coronary artery disease. For example, if it's the LED, you have to follow the LED course of supplying the myocardium. I mean, could affect the septum, apex, most of the time, anterior wall, and then LCX or RCA. Every territory was a corresponding supplying myocardium. So subendocardium, usually this is the area started suffering from ischemia before the full the myocardial cells.
Thank you so much. I'm going to ask you to show us the angiogram, and then I will ask Dr. Safa to comment on this case altogether as another MRI expert on the panel today.
Sure. So this is the late gadolinium. It's negative for myocardial stroke. So we decided to proceed for coronary angiogram, and you can see here the right upper cine. You can see a significant lesion in the proximal part of the LED here. This segment, and also in the upper left part. It's also manifested here. You can see all this segment of the LED is diseased. Another view showing the LED in the right lower cine. Again, you can see significant lesion in the proximal part of the LED. In the RCA, also you can find it's severely atherosclerotic with multiple significant lesions starting from the proximal part and the mid region or mid segment, and also the distal posterolateral branch. So this is an example of intermediate risk patients, symptomatic and positive cardiac MRI for ischemia, and then also positive coronary angiogram for two vessel disease. And this patient underwent two vessel BCI and is doing well right now. And thank you.
Thanks so much, Dr. Walid, for this representative case. Why do you think so what you really highlighted was the inferoseptal hypoperfusion, which corresponds to the RCA, I'm assuming, correct?
Yes.
And the LED also tended to have disease, but I was underwhelmed by the extent of ischemia in the LED territory. Any thoughts, Dr. Safa, about this? What do you think about the case?
Actually, it was nicely presented by Dr. Walid, and I was amazed myself when I look at the LAD lesion, and there was not sort of a significant hypoperfusion seen in the LAD territory. Sometimes this can, because when we quantify that, we looked into the differentiation between different walls. So sometimes a balanced ischemia can give you this false negative. I did not see anything in the LAD, but you mentioned there was something in the septum, anterior septum, Dr. Walid, yeah? There was some subtle changes in the septum.
Definitely, yes. But actually the report came as positive in the RCA. But when you look at the study again, retrospectively, actually, we find, yes, at the level of the subendocardium of the septum, there was a hypoperfusion defect.
I think maybe the motion correction images maybe will be more clear. I think that if you could see it more if you do the motion correction algorithm, and then we can see maybe more in the LAD. But it's really nicely demonstrated how can you utilize the stress CMR in evaluating symptomatic patients, and then you proceed further and and going to the angiogram. At least you have in your mind a plan or a road map that you would really follow, and tells you that that territory is viable. There was no late gadolinium enhancement, so definitely the patients will improve symptoms, and these symptoms are ischemia in origin.
Thank you, Dr. Safa. Yes.
Dr. Amrish, you had your hand up.
Yes, I have my hand up because certainly this MRI did not at all show the proportionate the proportionate defects, what we see the angiogram. The angiogram has got multiple defects at multiple level. So I wonder that cardiac MRI is, if you look at this cardiac MRI and you're blinded for this angiogram, I don't think so. For me, for sure, I will never ever predict the extent of this coronary artery disease in this patient. It is possible on SPECT imaging. On SPECT imaging, we may find a total disappearance of the traces in the stress, in the LED, in the RCA. So in this modality, probably the CT angiography aspect would have given us much more clear about data regarding the significance of the lesions than the MRI. The MRI kind of underestimated the whole the angiographic findings in this patient.
Can I comment, Dr. Firas?
Yeah, go ahead, please.
So yeah, typically this patient, the positivity for ischemia in the RCA territory. But this is actually for all the non-invasive test modalities, this problem comes. So I have a patient, 2 weeks ago, I did CT coronary angiogram, and the CT reported moderate lesion, but I was not convinced. So I did nuclear scan, which came positive. So every test is not 100% sensitive, it's not 100% specific. But at least this report of the cardiac MRI leads us to send the patient for CAS, with confidence that this CAS more likely to be positive. So I don't have really too much explanation why the LAED was not reported as a hypoperfusion defect in the LAED, which is actually more important. But it was really positive for the RCA. Could be balanced ischemia, as Dr. Safa mentioned, but when we looked at the study retrospectively, there was a hypoperfusion defect in the subendocardium of the septum.
You know, I want to be mindful of the time, but the concept of balanced ischemia should not be really a concern in stress CMR for reasons as we discussed. You have a way superior, you have a modality with a much superior spatial resolution. Your ability to discern a gradient in tracer uptake or in contrast uptake, first pass effect, is a lot more superior than what you can tell with nuclear. And you can tell a finer gradation of a subepicardial, subendocardial gradient. You do not have the normalization issue that you have with nuclear, and every pixel or voxel is treated on its own in CMR.
Yes.
Last comment to Waleed.
Last comment. So this study was reported visually. So in the conclusion of the positivity of the stress cardiac MRI, we can do by software or by visual assessment. This was reported visually. There is a software that probably can improve our accuracy for documentation.
Okay, Dr. Safa, any comments?
I was really amazed because the LAD lesion is quite proximal, it's quite severe, and you should see more than just a very subtle septal hypoperfusion. So was that acquired in the right timing in terms of image acquisition? This is another thing. That was it technically done correctly? That's the other explanation for that.
Typically, we did not look at it from the quality standpoint, but I think, yes, we have to look at the quality of the study. Why was missed, the LAD lesion? But it's a good opportunity for quality improvement. Yes, I do.
Excellent. Dr. Hassan has been patiently waiting. I would like for him to share his case before we run out of time.
Yeah, Dr. Firas, I have a small comment regarding this balanced ischemia. I'm not an MRI expert, but I don't think so. There is a balanced ischemia in stress MR. So I think there is some quality issues, or maybe the reporting.
Yeah, there might be something unique about this study, but balanced ischemia should be less of a concern. I agree with you with stress MR. Do you want to share your case where you've been patiently waiting, and we want to highlight another aspect in chest pain evaluation here, and thank you for preparing this case, Dr. Hassan.
So thank you very much, Dr. Firas, for giving me the opportunity and be a part of this elite panel. And I'm really thankful for the Emirates Cardiac Society as well. So my case is not a very unusual case. It's a very routine case that we usually encounter in our clinical practice. So day-to-day practice. So basically, she's a 56-year-old female with long-standing history of untreated hypertension and dyslipidemia. So, and she doesn't have any history of premature coronary artery disease, and she doesn't have any addictions. And she was taking on and off atorvastatin for dyslipidemia, but she was not on any antihypertensive medication. So she presented to the cardiology clinic for the evaluation of exertional chest pain, and that was there for several months, and that seems to be very typical of stable anginal chest pain. So like ECS class 2. So as a routine part of the chest pain evaluation, we did an EKG. So the EKG is here. It shows normal sinus rhythm with normal intervals, and there is a borderline LVH, but it's quite interpretable type of EKG. And then as our routine, we order an echo as well for cardiac evaluation. So unfortunately, I don't have the echo images, but the echo was her cardiac chamber was normal, left ventricular systolic and diastolic functions were normal RV function, and no significant valvular abnormalities. So this is the concern of our discussion today. So what are the modalities that we can start with, and we can begin with this to investigate further. So as we already discussed, considering the pretest probability, she is likely a low to intermediate risk. So we started with treadmill stress testing. So this is the baseline pre-exercise EKG, and this is the early recovery, and patient exercise for about 7 minutes, and she stopped because of limiting anginal pain, and the EKG showed less than 1 mm or maybe 1 mm upsloping ST depression. So it was reported as an equivocal stress test, okay, with DTS of -1 in the intermediate risk category. So again, the patient is symptomatic but with stable symptoms. So again, what do I do now? So this is the topic of our discussion. So considering the positive equivocal stress test, and now the patient have stable symptoms, so we proceed with coronary CT angiogram. So our calcium score is 22 and found to have left main is not significant. There is no significant plaques, but as you can see, there is a mild to moderate mixed plaque in the proximal to mid LAD that was reported like 25 to 50%, and then in the mid LAD there is some motion artifact as well. So, but there is there is a contrast in the distal LAD, so there is no significant obstructive disease in the mid to distal LAD. So the circumflex is also, there is minimal plaque in the proximal circumflex and mild non-calcified plaques in the mid circumflex. So, and you can see in the RCA there is moderate non-calcified disease in the proximal RCA. So what do you think? What should we do now? So
this is a great case, Hassan. Thank you so much. Let me ask Dr. Amrish, would you have sent this patient to a plain treadmill test, knowing what you know about her, or would you have chosen an imaging-based modality at the get-go?
See, in this patient, probably we would have gone for a CT angiography as the first choice for this patient, which anyway this patient went, so there is no harm doing a functional testing before. But in our hospital, probably this patient would have gone for a CT angiography before, considering this patient got a chest pain and the EC is normal, so it's interpretable and no previous stenting done before, so you'll be a good candidate for CT angiography. And all these patients will make sure that heart is less than 60. So the heart rate less than 60 is very important to get high quality images.
Can you tell us why is that important? And a couple of speakers emphasized this. Why is that important from a technical standpoint?
Well, obviously the coronary flow occurs in diastole, and the way the CT angiography work is that it integrates the diastolic frame to generate a coronary angiogram in the CT scan. So the more prolonged and more stable the diastole, more consistent the diastole, the more accurate and the more clear the images with no artifacts.
Dr. Safa, what do you think of the burden of atherosclerosis on this patient, and what would you do next in terms of management, preventative therapies, revascularization, others?
Well, I'm not sure about that mid-LAD lesion. It was mentioned that there is a motion artifact. I would really rather look further into that by looking into a different percentage of a cycle in systole or something else, try to assert it. But from looking at these limited images, I think there was no severe stenosis per se. The patient is a lady who is, I would put it into moderate risk. Correct me, Dr. Hassan, if I'm wrong. She's hypertensive, I think.
Yes. Intermediate risk, yes. Pretest probability of intermediate. Yeah.
And you did not see in coronary and in the CT itself any significant lesion. Is that correct?
Yeah, there is no. Yeah.
Can you go back to your CT? RCA.
Yeah. So the only lesion that is concerning is this proximal RCA lesion that is at max is moderate, and it's a non-calcified lesion. Okay, and while on other phases it's not a significant obstructive disease in the mid LAD. Okay, so it's mixed
and the symptoms were typical.
Yes,
and the symptom were cardiac in origin.
Yeah, it's typical of anginal symptoms, exertional symptoms, but it's very much stable, and it's over the period of several months.
So I think, from my point of view, I think what I would do, I would not stop that there, because there is a sort of a proximal moderate or moderate to severe RCA with the patient who is symptomatic. It's very difficult to comment on it in that, but it looks like going more into moderately severe RCA lesion. So the next step is, would you go directly and doing an invasive angiogram with FFR, or would you go back and do another stress modality such as stress CMR or a CT PET or other stress modality, or stress echo if you have the sort of comfortable doing that. So that's really, there are multiple choices here, and again, it depends on how comfortable you are with the services that is provided in your institution.
Let me just play the devil's advocate and say, this patient had evidence of ischemia on ECG, albeit equivocal in this case, and she has epicardial coronary disease, but no left main involvement. So technically, she could have qualified to ischemia trial. And what we learned from ischemia trial is that there is no penalty for deferring initial angiography and revascularization, and treating the patient medically upfront is really not hazardous or not associated with hazards to the patient. So would you treat this patient medically? I'm going to go around and ask Dr. Safa and Dr. Amrish.
I will not. I don't feel comfortable to stop there. I know there is growing evidence of maximized medical therapy, but still, I will not be happy to leave that proximal RCA lesion. There is no left main, as you mentioned. There is no sort of a proximal LAD, but the lady is symptomatic. So I think I would go further and assess that more.
Dr. Amreen?
See, Dr. Feras, if you see the American guidelines, in this patient, the guidelines will recommend to do an FFR-CT. FFR-CT in this patient, because now we find lesions of CT angiogram, patients having pain, intermediate probability. So the guidelines recommend the second step is FFR-CT, and they are saying that FFR-CT is probably even more better than invasive FFR to signify the stenosis. So in this patient, I wonder if you can do FFR-CT, because we don't have much experience. Can you do FFR-CT retrospectively, or FFR-CT protocol has to be built in at the time of acquiring the initial images?
We do not have FFR-CT. What usually happens is typically the analysis occurs off-site. So in the United States, the sites that have access to this will transfer. So a CT with a suspicious obstructive lesion, the entire data set is transferred to the company that performs this, that has a proprietary rights, and it will generate a map, a colored map of the coronary tree with predicted FFR values based on computational fluid dynamics to assess the severity and significance of these stenoses. And this will be turned back to the physician. And depending on where you are in the States, what time you send it to them, you may get it back in 24 hours or less or more. So a lot of times you will get your CT FFR after the patient has left or gone home from their study. I agree with you that an FFR-CT would have made this more objective in terms of assessment, the severity of the disease.
So in the absence of FFR-CT, if you ask what I will do in my clinical practice in our hospital, this patient has obviously symptoms and the lesions are not very clear. So we will either subject this patient to invasive angiogram, or another viable alternative is, very good alternative is to do a SPECT scanning for him. The SPECT scanning will define the territory of ischemia, will define the percentage of ischemia, and the trial from the ischemia trials and the COURAGE trial, they say that if you have a percentage of defect less than 10%, then there's a very low probability of having problems later on, and this patient can probably be left alone. And 20% or more, then you will have to revascularize this patient. So this is what I was thinking in the mind.
Okay.
Just a quick comment.
Hassan, you want to close that? Because I want to be mindful of everybody's time.
I want to ask Hassan one question. This is dominant left or right?
It's a dominant right system.
Right system.
Yeah.
So if you ask me, this lesion, which is not clear really, I do agree with Dr. Safa, is probably more than moderate, but I will start with the medical trial first. If it is controlling her symptoms, because I can see the flow at the distal, in the mid and distal RCA is good as the proximal part. So I don't think this is a limiting flow lesion, but if the medical treatment is controlling her symptoms and she's doing fine with medical treatment, I will defer invasive strategy.
Hassan, why don't you tell us how this patient did, and we'll take maybe one last comment before we adjourn.
So, considering all the findings, it's a very, very healthy discussion, and it's always being a dilemma where what to do next. So with stable symptoms, I started her on medical therapy, with no left main disease, no significant proximal LED disease. So in my view, there is no I think there is no mortality benefit in revascularization or going for invasive angiogram, and so I started with medical therapy and optimized her medical therapy, and started on her own aspirin because she has coronary artery disease, some beta blocker, nitrates, and statin. So she's doing fine. She's compliant to her medications, and currently she is angina free now.
Excellent. Excellent. Dr. Safa, you had a comment? We'll give you the last word for the night.
I just had a comment on about indicating significant or non-significant lesion based on the distal flow in coronary CT. Usually, we don't really rely on that. We because of the dye can reach the distal even if there is occlusion. So just to clarify this point.
Absence of dye may indicate occlusion, but I agree with you with your comments, 100%.
And
well,
with collateral flows, you can have distal with collaterals, you can have dye in the distal segment if you have a totally occluded vessel. Absolutely, I totally agree with Dr. Safa.
Well, we're 8 minutes above our allotted time. This has been a very healthy and very inviting discussion. I would like to thank each and every one of you for taking the time to contribute to this session. All of your presentations have been absolutely outstanding. Thank you so much for taking the time to share your cases and do your presentations. And we're hoping, and I surely hope, that by continuing our activities around patient-centered imaging and about the multimodality role of all cardiac modalities in improving patient care and improving patient outcomes. I think we have a lot of work ahead of us, but it takes a motivated group like you all to keep our field moving forward. So I would like to thank you again. I would like to thank the audience for sticking around and being part of this program this late. And stay tuned for we have a special treat for you for our next session in May, inshallah. So with that, I would like to thank you and wish you all a good night. Assalamu alaikum wa rahmatullahi wa barakatuh.
Thank you.
Thank you very much.